Good evening, students. Today we'll be discussing about lumbosacral plexus, clinical and electrophysiological discussion mainly. We'll have some interactive questions and I appreciate if you can answer those questions. So there are about 25 of them. This will help us in understanding each other and also uh, understand the lumbosacral plexus better. So the scheme will be, we'll deal with anatomy and the structure of the lumbosacral plexus, and we'll try and see how to localize and differential diagnosis of various disorders that cause this, the main important aspects in localizing and considering differential diagnosis, the electrodiagnostic features, and I'll be dealing here slightly into the electrophysiology of nerve. We'll be discussing about nerve conduction velocities, the distal latencies, the compound muscle action potentials, the conduction velocities, the F latencies, the H reflex, and the needle EMG, and the spontaneous activity, the motor unit action potentials, the interference patterns, and H reflex mainly in lumbosacral plexus. And we'll have a couple of case studies also. the plexus versus direct narrow root innervation. Why nature has created this plexus, and which complicated our learning a bit, both in brachial plexus and lumbosacral plexus, is only to help us, and it diffuses the risk of trauma. So even if trauma happens, not much of damage is done. If individual nerve is damaged, then there will be a lot of damage. So one of the important aspects what you should remember is lumbosacral plexus involvement is common in trauma and cancer. So plexus involvement is equal to trauma and cancer. So you should remember this. First we'll think of anatomy, and then a systematic approach of localizing the pathological site. To consider that, again I'll repeat this again, later slides also. What we are encountering is involving only one limb, that is mononeuropathy, plexopathy or radiculopathy. And so all three can involve one limb. If it is more than one limb, that is polymelic, it can be systemic disorders. So pure sensory is ganglionopathies, pure motor is motor neuropathies, or polyneuropathy or polyradiculopathy. So our interest is mainly when we are looking at the lower limbs, and it is mononeuropathy, plexopathy or radiculopathy. These are the three important things. And you see the plexus, roots, divisions and nerves here. Roots, RTDC, roots, trunks, divisions, cards and nerves in cervical plexus, which we'll take up in the later classes, but here it is roots, divisions and nerves. So you should know the important nerves in the lower limb, and starting from the nerves originating at the roots level, which are called root collateral nerves, and roots directly coming, giving rise to nerves, and the plexus giving rise to nerves, and the sciatic nerve, common peroneal and posterior tibial nerves on the posterior aspect, posterior cutaneous nerve of the thigh, and anteriorly you have femoral nerve, obturator nerve, saphenous nerve, spherical nerve, and various other things. And these are all coming from L2 to S2 narrow roots. So you can divide them into upper plexus and lower plexus. L2, 3, 4 is upper plexus. L5, S1, S2 is lower plexus. And their symmetry, as far as nature is concerned, it tried maintaining symmetry on both sides of the body. So L2, 3, 4 is upper plexus. L5, S1, S2 is lower plexus. And it can be further divided into anterior divisions and posterior divisions, and the anterior divisions and posterior divisions of lumbosacral plexus will have ilio-hypogastric, ilio-inguinal nerves coming from L1 and genitofemoral nerve. You can see the anterior divisions are in yellow color and the posterior divisions are in the dark color, and you have lateral cutaneous nerve of thigh coming, and you have to nerve to iliopsoas and of a femoral nerve. They are coming from the posterior divisions, and you got some obturator nerve which is coming from the anterior division. So the lumbosacral plexus, the lower plexus, and lower plexus, as you said, that fibular division and tibular division. This is L4 downwards. That means L5, S1, S2, S3. This is lower plexus. The upper plexus is L1, L2, L3, L4. So L4 partly it comes to lower plexus. And lower plexus mainly gives rise to the sciatic nerve, fibular and tibial divisions, and you have posterior cutaneous nerve of thigh here. There are two important nerves which are here: superior gluteal, which supplies the gluteus medius, minimus and tensor fasciae lata, and inferior gluteal nerve which supplies the gluteus maximus muscle, which is, they are not part of the sciatic nerve. Just observe this, they are not part of the sciatic nerve. These are important nerves. They are called root collateral nerves or proximal nerves. They had a very important role in localizing lesions. The upper plexus divisions, posterior division, as I said earlier, lateral femoral cutaneous nerve of thigh, which causes meralgia paresthetica when it gets pressed underneath the inguinal ligament, and the femoral nerve, which is supplying the quadriceps femoris and all other knee extensors, as well as it gives rise to the terminal branch of the saphenous nerve, which supplies the sensations in the medial aspect of the leg. Anterior division gives rise to obturator nerve, which supplies the adductor group of muscles. The adductor magnus has got dual supply along with sciatic nerve. So the femoral nerve, Q-tips, quadriceps femoris, articularis genu, rectus femoris, sartorius. That's how you remember these femoral nerve supplied muscles. So upper plexus, posterior division nerves are femoral nerve, and the one nerve that comes directly is lateral femoral cutaneous nerve of the thigh. The proximal root nerve, so the femoral nerve is responsible for hip flexion, knee extension, supplies muscles quadriceps femoris, articularis genu, iliopsoas, pectineus, and sartorius. It terminates as saphenous nerve. So this much you should remember, and this anatomy is very much we're going to discuss again. The anterior division nerves are L4 branch to lower plexus, include sciatic innervated, adductor magnus. I said adductor magnus has got two or dual supply, and obturator nerve as well as sciatic nerve, which supplies the adductor group of muscles. So the obturator nerve, adductor longus, adductor brevis, adductor, this is a dual supply, and mononeuropathy is rare and manifests as thigh adduction weakness. If there is no history of trauma or cancer, then radiculopathy is implied. In lower limb, remember only three: mononeuropathy, plexopathy, or radiculopathy. Plexopathy, if there is a history of trauma or cancer, you consider plexopathy. If not, it is either mononeuropathy or it is radiculopathy. So PIVD is rare, rostral to L5, and so infectious or inflammatory causes come into play. So right. So this is again the same I have already mentioned about the, again I am showing this superior gluteal and inferior gluteal. We'll discuss a lot in the question period. The lower plexus nerves and the gluteal media, the superior gluteal nerve, the tensor fascial lata, gluteus medius and minimus is supplied by superior gluteal nerve, and it is not coming from sciatic nerve. Again I am telling, when we discuss questions that will come into handy for you, the inferior gluteal nerve is gluteus maximus, and sciatic nerve, adductor magnus, posterior thigh muscles and muscles distal to knee that are not supplied, all the muscles that are supplied distal to the knee. So branch to adductor magnus, tibial division and fibular division. These are the main sciatic branches in the thigh. And superior gluteal nerve and inferior gluteal nerve originate proximal to sciatic nerve and supply the muscles which I already mentioned. Their involvement disapproves as sciatic neuropathy. So whenever you suspect sciatic neuropathy, the most important examination clinically you have to do is hip extension. Whether hip extension is involved or not will decide where your problem is. If extension of hip is not involved, it is sciatic neuropathy. If it is involved, it is radiculopathy, right? So sciatic nerve in thigh, branch to adductor magnus, divides in tibial and fibular divisions. The tibial nerve supplies posterior leg and all non-extensor intrinsic foot muscles and terminates as sensory digital branches in foot. Fibular nerve is foot aortas. So there is a main differentiating feature between tibial and fibular nerve. The common peroneal or common fibular nerve is dorsiflexion and eversion. The tibial nerve is plantar flexion and inversion. The fibular nerve, the superficial peroneal, is called foot aortas, peroneus longus and peroneus brevis, and sensation over the dorsum of the foot. The dorsal fibular nerve, or the deep peroneal nerve, foot dorsiflexors, and sensation over the skin between the great toe and second toe. So you now have an idea from whatever I said, that is tibial nerve and peroneal nerve, how they distribute. So differentiate various pathologies of lumbosacral plexus disorders between mononeuropathy, radiculopathy and plexopathy. These will come into more into picture when we discuss cases. Sorry. The roots divide directly to form nerves. Is it first answered monomelic or polymelic, which we have already mentioned? Again I told you in the beginning also, I'll again come back to this understanding of mononeuropathy, plexopathy or radiculopathy is very, very important, because pure motors are ALS, neuromuscular junction disorders and myopathy, they cause polymelic. Pure sensory polyganglionopathies and sensory neuronopathies are polymelic, and polyneuropathies are polymelic. So we will not be discussing polymelic, and we will be discussing only monomelic subdivides to mononeuropathy, plexopathy or radiculopathy involvements. So patterns that disapprove mononeuropathy. So that means a person has come with some complaint, and you have to decide whether this individual with left limb weakness, whether he has got mononeuropathy, plexopathy, or radiculopathy. So three important aspects which you should see: weakness of hip flexion and thigh adduction. Hip flexion is femoral nerve, adduction is obturator nerve. So L3 and L4, you have to remember this. Weakness of foot inversion and eversion. Inversion is tibialis posterior, tibial nerve L4. Eversion is peroneus longus and brevis, that is S1 fibular nerve. Weakness of limb muscle and gluteal muscle, gluteus medius L5, gluteus maximus S1. Why you should know is, in all examinations of foot drop or flaying foot drop, you have to concentrate how whether inversion and eversion, dorsiflexion, plantar flexion of the foot are involved or not. So depending on that, you can localize the lesion. So some thumb rules, lumbosacral plexus disorders. So these thumb rules are very, very handy for us. Radiculopathies are more common below L4. Proximal lower extremity weakness is not likely to be radiculopathic. So radiculopathies are more common below L4. That means L5, S1 radiculopathy. There is no L2, L3 radiculopathies. Foot drop may result from L5 radiculopathy, or it could be because of common peroneal or fibular neuropathy. So S1 radiculopathy to be differentiated from sciatic neuropathy. S1 means gluteal muscle weakness should not be observed in sciatic neuropathy, which I have already mentioned. Mononeuropathies are very less common in this. And what are the mononeuropathies that are encountered? Femoral neuropathy and lateral femoral cutaneous nerve of the thigh, which we usually see. That is meralgia paresthetica. Right. So next we'll move on. So these are the hot vintages: the hereditary, occupational, trauma, vascular, infectious, neoplastic, toxic, metabolic, autoimmune, gender-related, electric events, secondary effects. All these can cause lumbosacral plexopathy involvements. So some are chronic, some are acute, and next slide I'll show you what are the acute insults that can happen, and you can remember them. And that is trauma, acute, evident on history; vascular, acute is ischemia or hemorrhage; electric events, loss of conduction and demyelination. These are the acute events that will affect. So the laboratory investigations, mainly they depend on, one is clinical history, examination, and electrophysiology testing, and CT-MRI, radiculopathy, CT-MRI and LP if infectious, inflammatory, or immune process is suspected. So a 68-year-old man who is an hypertension case and NIDDM and chronic obstructive lung disease, he has got a pain in the lower extremity followed by foot drop. Left foot dorsiflexion and inversion weakness is there. Absent ankle reflexes with decreased vibration from the ankles distally bilaterally. The recent onset of left foot drop with weakness of left foot dorsiflexion and inversion. So what is the localization here? Left tibial nerve, common peroneal nerve, left lower lumbosacral plexus, left L5 nerve root. What is the? Keep guessing. So we'll have some interaction. So there are more questions. Whenever, yes, you can write. That's nice. I'm happy that somebody has. L5.
Hello, sir.
Yes, Suresh Reddy. Yes, you can tell.
Hello, sir.
Yes.
Foot dorsiflexion
Huh.
is secondary to common peroneal nerve weakness, and
Yeah.
inversion is secondary to left tibial nerve weakness. So
Yes.
it can be either. So it can it be above the division of the common peroneal and tibial?
Yes. So it could be L5 radiculopathy. It's not common peroneal, not tibial. It's not plexus because no history of any cancer or trauma. So it will be L5. Okay. All right. Thank you. Okay. Thank you. That's nice. So foot dorsiflexion is peroneal nerve. Inversion is tibial nerve. The possibilities are mononeuropathy, sciatic mononeuropathy, radiculopathy, or plexopathy. These are the only Three. By thumb rule, we rule out mononeuropathy because of rarity. Only femoral and lateral femoral cutaneous nerve are involved in the lower limb. Plexopathies are usually secondary to trauma and cancer, which is not the case here. So radiculopathy L5 is very important. One of the important features of radiculopathy L5 is the reflexes are preserved. So don't look for absent reflexes in L5 radiculopathy, because L3, L4 is knee, and mostly it is S1 is ankle. So L5 is usually goes elicitable. Motor, sensory and reflex findings. Weakness in one nerve territory. Weakness in more than one nerve territory suggests either plexopathy or radiculopathy. But in lower limbs, the mononeuropathy is very rare. Plexopathy is secondary only to trauma and cancer. Most common mononeuropathies, common peroneal fibula at the head, that which we can already diagnose. We can diagnose easily. The radiculopathy, most common cause of more than one neuropathy, may be combined with a plexopathy in severe trauma and diabetes. So diabetes is one condition where you get both plexopathies and radiculopathies. Plexopathies are rare, and cancers and local treatment of cancer and trauma only can give rise to. So patients presents with right lower extremity weakness. There is weakness of the right foot dorsiflexion, inversion and eversion. There is no history of trauma or cancer. So based on whatever I said, you all can easily say what is this: mononeuropathy, plexopathy or radiculopathy.
Radiculopathy, sir.
Very good. Okay, good. Next. So a patient reports right lower and so sorry, this way again I think it's come. Now we'll have the objective testing, that is in lab what we do. So I hope all of you do nerve conduction studies in your laboratories. In upper limbs, we try and do median and ulnar nerves, and we try and do motor nerve conduction studies and sensory nerve conduction studies, and we also look at the F waves. And in lower limbs, common peroneal and posterior tibial nerves are most commonly done, and then we do the needle electromyography, EMG. The sensory nerve action potentials are requires three structures to function, that is myelin sheath, vasa nervorum and axon. This is a very difficult to elicit, but all of you should get the median snap, the ulnar snap and the sural snap by yourself. You will have to elicit and see the difficulties in, and the waveform is very important. CMAP requires the following structures for the proper functioning: myelin sheath, axon, vasa nervorum, motor nerve end plates, neuromuscular junction and muscles. See, the compound muscle action potential is what we elicit on nerve conduction studies, and motor unit action potential is what we elicit on EMG. So this is the F wave. When you stimulate the nerve, it goes to the axon and comes back. Whenever anti-horn cells are destroyed and this F wave will be absent, it will be a prolonged F wave in cases of AIDP and radiculopathies. So mostly the F wave is also an important aspect which you will have to do. And the H reflex, which is again, it is a sensory stimulus in the tibial nerve in the popliteal fossa, which will go to the spinal cord and come back and stimulate the gastrocnemius and soleus muscle, and you can see the H reflex. And the arc, it is equivalent to the ankle jerk. So sciatic nerve and S1 radiculopathies will affect the H reflex. So after that, you see the muscle at rest, muscle with voluntary contraction. In all cases of EMG, as you put the needle into the muscle, we should look at the insertional activity and ask the patient to keep the hand or leg very quiet and look for spontaneous activity. Fibrillation and positive short waves have to be elicited, and mild tension, mild effort will give rise to motor unit action potential, and the forced thing will give rise to what is called as interference pattern. Right, Arvind, yeah, thank you. Right, oh, good. Right, now we'll have more interactions later on. So the mononeuropathy, abnormal snaps one nerve territory only. Abnormalities are restricted to one nerve only. Abnormal late response is limited to one nerve only. The paraspinal EMG is normal. So the paraspinal EMG or paraspinal muscles, can anybody tell what is the importance? Why should we do
Root,
paraspinal muscle? Yes, somebody can
root
explain.
involvement, sir.
Root involvement. So how are the plexus formed? Just tell me. Dorsal root. ventral root. How the plexus formed? Yes.
Combination of
How the
nerves,
huh?
like combination of various nerves.
It's not like
Like
that. You have to tell correctly. Ventral root and dorsal root join to form what?
now
Spinal nerve. Then what
spinal
happens?
nerve.
Then what
Uh,
happens?
Various spinal nerves combine to form plexus, like L2,
No, no,
L3.
no, 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 no. That is wrong. The nerves will divide into anterior primary rami
Yeah.
and posterior primary rami. You got it?
Yes, sir. Yes.
Anterior primary rami join to form plexus. The
Okay.
posterior primary
Posterior
rami goes to paraspinal
paraspinal
muscles.
muscles.
This is
Yes.
the point which I wanted to highlight. That's why many people don't understand this point. Posterior rami supplies paraspinal. That's good, but many people may not know it. So you should remember that this is the anatomy that's very important. And after mononeuropathy, we'll go on to the second phase. Abnormal snaps in plexopathy, because this is distal to dorsal root ganglion. Plexopathies are always distal. Abnormal late responses. Abnormal paraspinal EMG is normal here. So that dorsal root ganglion is a post-ganglionic lesions. Plexopathies are always post-ganglionic lesions. And radiculopathies, snaps are normal because they're preganglionic. And variable late response, that means F waves. The paraspinal EMG is always abnormal. So it is difficult to locate to one root only. So now we understood what are the three aspects, right? So this is the picture radiculopathy description. This is the preganglionic lesion. That's why the snaps are normal. The MUAPs may be slightly affected. The F wave responses are also may be affected in this. The root, this is same radiculopathy, and they can CMAP remains normal as muscle receives the for the supply from other neurons also. So CMAP can be normal. The plexopathy is the distal, postganglionic. So snaps are always abnormal, though it is shown here, but usually the snaps are absent here. That's how you pick up plexopathies, and the CMAPs may be affected or may not be affected. Snaps are very important for us in this case. The anterior horn cells, here also it's again paraspinal muscles are involved, and see here the anterior horn cell means your snaps are always normal. Snaps are always normal. CMAP may be diminished, and the if CMAP is diminished, F wave may not be elicible also. The F wave depends on the amplitude of the compound muscle action potential. So what are the important things the which we have to discuss here? All motor fibers distal to antihorn cells are affected, and paraspinal muscles, truncal and proximal muscles, and limb muscles are all affected. Dorsal root ganglion and distal sensory nerves are intact. So in this case, stimulation of the limb sensory nerve results in a normal snap. So that's an important aspect. So sensory nerve action potential elicitation is very, very important. So let us see what are the patterns of root lesions. They got no effect on snaps because pathology is proximal to dorsal root ganglion. There will be denervation of the paraspinal muscles is possible, so EMG may be abnormal. Plexus is abnormal snaps, paraspinal muscles are unaffected. Nerve lesions, abnormal snaps in one nerve only, and muscles affected more than one nerve. Okay, yes, right. What's it? Can we differentiate AH lesion and root lesion? Yes, AHC lesion will have, see, in the sense the F wave. F wave is usually uh, related to the CMAP amplitude. So snaps are, it's a bit difficult because it's root lesions and AHC lesions, but it's a clinical electrophysiological correlation you may get on EMG. That's why EMG is a must. Whenever there is a CMAP uh, problem, abnormal CMAP, EMG has to be done. That's the reason. That's why EMG giant action potentials will tell us and that it is a anterior horn cell thing. So that's important. Now abnormal EMG will help us in that. That's how we can differentiate. So L5 root, again, gluteus medius, magnimus, and tensor fascial later, L5 root. L4, S1 root, inferior gluteal nerve, that is gluteus maximus. The H reflex, which we have tibial nerve at the knee and response to gastrocnemius and soleus, which I said. So the pathology of S1 radiculopathy and sciatic nerve will be usually understood by studying the H reflex. H reflex is more sensitive than ankle jerk. Even if ankle jerk is absent, H reflex can be still present. So, sensory nerve conduction studies, motor nerve conduction studies, late responses, inching studies, and needle EMG all put together, we can diagnose a case. The history and physical examination leads to hypothetical localization. The likely anatomical localization confirmed using EMG and NCV. SNAP abnormalities are distal to the dorsal root ganglion. CMAP abnormalities should be tested with needle EMG. Needle EMG will help in differentiation. Anatomical localization depends on CMAP, SNAPs, FN, nerve conduction velocity, and H reflexes. So these are the important issues. So a 20-year-old suffers road traffic accident and reports acute onset of right thigh weakness and sensory loss in his right leg. Examination shows grade 3 power in the right hip flexion with sensory loss over the medial aspect of his leg and absent right patellar and knee reflex. Paraspinal EMG would be normal, yes or no? That's a question you have to answer. Read the question again. Whether paraspinal EMG would be normal or no? Hip flexion weakness? Some answers have come. Right? Yeah. Normal. Okay. Yeah, that's it. Very good. So, examination grade 3 hip flexion is by femoral nerve. Sensory loss over the medial aspect of his leg is saphenous nerve. Absent right patellar reflex is L2, L34, L34. So, that's correct. A man receives IM injection in his left hip and experiences acute onset of left flail foot with pain radiating down the extremity. His left ankle reflex is absent, as is the left H reflex. The left sural and fibular snaps are also absent. So here the needle EMG of the gluteus medius would be abnormal. Is it true or false? Yeah, that's nice. False. Why? Man with IM injection, he has got a flail foot. That means both dorsiflexion and plantar flexion both are affected. And so the left sural and fibular snaps are absent. So snaps are absent means flexible. So the gluteus medius would not be affected. Right? Very nice. Next question. An individual develops progressive painless weakness in the right lower limb, right flail foot, and absent right ankle jerk. The common peroneal and posterior tibial stimulation showed no CMAP. The right snap is normal. Needle EMG demonstrate widespread denervation in the both lower extremities, the lumbosacral paraspinal and mid-thoracic paraspinalis. Is this a radiculopathy? Yes. Is it? Then why the mid-thoracic paraspinals? The lumbosacral paraspinal is okay. Mid-thoracic?
Anterior horn cell, sir.
Anterior horn cells. Oh, yeah. So this is a false. This radiculopathy is not correct because you have this mid-thoracic paraspinals. So it's not a radiculopathy, right? Got the point? Everything is suggestive that could be lumbar, but EMG has given us a clue that it is not radiculopathy. Somebody asked the question. I think we got the answer now. I think, isn't it? Yeah. That's somebody said false. That's correct. We got the answer also. A 75-year-old develops acute onset of severe pain in the left posterior thigh, followed by a flat foot. Clinical evaluation shows absent left ankle jerk. EMG 3 weeks later showed absent snap, absent left superior peroneal snap, absent posterior tibial CMAP, and common peroneal CMAP. EMG showed spontaneous activity in the left adductor magnus, left short head of the biceps femoris, left tibialis anterior. The correct diagnosis is sciatic mononeuropathy, S1 radiculopathy, lower lumbosacral plexopathy, motor neuron disease. Just remember that he has got a pain in the left posterior thigh followed by a flat or flail foot, not flat, but flail foot. So 3 weeks later showed the spontaneous activity in the left adductor magnus, that is sciatic, short head of the biceps femoris, left tibialis anterior. So is it a sciatic mononeuropathy? Is it S1 radiculopathy or lower lumbosacral plexopathy? Somebody, yeah, some concepts we got. Sciatic mononeuropathy, sciatic. Oh, good. Right. So, sciatic mononeuropathy is the correct answer. And so, this man, monomanic disorder, radiculopathy, plexopathy, mononeuropathy, we have decided. Absent snaps. So, radiculopathy and motor neuron disease are excluded because the snaps are normal. No antecedent history of trauma or cancer. So, though snaps are absent here also, they are excluded. EMG showed spontaneous activity in the adductor magnus supplied by both obturator nerve and sciatic nerve, also by the L2, L3 and L4. So the correct diagnosis is sciatic mononeuropathy. So adductor magnus is having a dual supply. Right. Which of the following electrodiagnostic findings will differentiate L5 radiculopathy from common peroneal neuropathy? Low CMAP, amplitude of a common peroneal nerve, absent H reflex, fibrillation potentials in the tibialis posterior muscle, lower magnitude of a sural snap. L5 radiculopathy from common peroneal neuropathy. Yeah, that's good. Very nice. Oh yeah, that's very good. That's very nice. Excellent answer. You got it. Right. So, fibrillation potentials in tibialis posterior muscle. The low CMAP can be seen in both conditions as L5 root supplies fibers to foot dorsiflexors, everters, and toe extensors through the common peroneal nerve. H reflex, as I said, is the electrodiagnostic equivalent of ankle jerk. So it will be normal in both CP neuropathy and L5 radiculopathy. Sural nerve divides into two parts that join the tibial and peroneal portions of the sciatic nerve. So it will be spared in both these diagnoses. Spontaneous activity in tibialis posterior innervated by tibial nerve may be observed in L5 radiculopathy but not in common peroneal nerve neuropathy. So that's why I said EMG is very important whenever you have a CMAP abnormality. All CMAP abnormalities are to be subjected to EMG. Right sciatic mononeuropathy. Which of the following findings are observed? FIPS and the positive shock waves in right gluteus maximus, absent H reflex, absent right saphenous snap, FIPS and positive shock waves in L5 paraspinal muscles. Now that's, you should be able to tell this. Yeah, that's it. So can you explain why, Suresh? Why not gluteus maximus?
Because it is root collateral, sir.
Root collaterals, okay.
So it is
Right.
not involved.
And saphenous?
Saphenous is basically femoral L2, L3 involvement. It will be lost. L2, L3,
It's a terminal branch of the femoral nerve.
femoral nerve.
So, right, that's nice. Others are following, no? So it's not only for Suresh, everybody should know. Right. So gluteus medius is supplied with superior gluteal nerve, not a branch of the sciatic nerve, hence incorrect. Saphenous snap is termed by the femoral nerve, hence not affected in sciatic neuropathy. FIPS and positive shock waves in paraspinal muscles are seen in lumbosacral radiculopathy and would be normal in sciatic neuropathy. H reflex is recorded from gastrocnemius and soleus complex. This is a monosynaptic reflex with sensory afferents that travel rostrally in the sciatic nerve, its tibial division to the target muscle. So abnormal H reflex could be seen in sciatic mononeuropathy and S1 radiculopathy and sciatic mononeuropathy also. A 50-year-old 188 centimeter tall individual develops pain in the left lower extremity followed by left foot plantar flexion weakness. Clinical evaluation showed grade 4 power and plantar flexion, loss of pinprick sensation over the lateral aspect of the left foot, and absent ankle jerk. What is the working diagnosis? Left sciatic mononeuropathy, L5 radiculopathy, upper lumbar plexopathy, lower lumbar plexopathy, S1 radiculopathy. This is a plantar flexion. Oh yeah, that's nice. That's nice. Somebody has answered this. Yes, S1, absent H. What did you say? S1. That's nice. Excellent. So this is, does the following electrophysiological findings support the diagnosis? Now you have to see the electrophysiological findings. So the yeah, your suspicion is correct. We have clinically came to a diagnosis that it could be L1. Then we'll see at the let's comment on this. Sensory nerve conduction studies are normal, left sural, left CP. The motor nerve conduction studies are showing the latency 5.3 in posterior tibial, 14.3. These are normal, right. Then the F latencies of tibial and common peroneal and H reflexes are all normal. So the FIPS and positive sharp waves are seen in adductor hallucis longus and gastrocnemius, and recruitment is reduced, interference decreased. So everybody is following. Tibialis anterior, rectus femoris, adductor longus, there are no FIPS. This is normal findings. Again, you are seeing in gluteus maximus and lumbosacral paraspinals. When paraspinals are involved, you have to have radiculopathy diagnosis in mind. Okay. So all sensory late responses and motor studies are normal. EMG demonstrated spontaneous activity in several muscles innervated by the different nerves as well as paraspinal. So findings are suggestive of radiculopathy. Right. Now, 60-year-old known case of hypertension, diabetes of 10 years, prior history of L5 radiculopathy, developed pain in left thigh followed by worsening of his existing left foot drop. Clinical evaluation showed grade 3 power left hip flexion, grade 3 thigh adduction, grade 4 left foot inversion, eversion, dorsiflexion. There is a new finding, that is absent ankle jerk. So what is the clinical diagnosis? Recurrent L5 radiculopathy, left sciatic mononeuropathy, left lower lumbar plexopathy, femoral neuronopathy, radiculoplexoneuropathy. This is a challenging question. Yes, nobody is coming forward. The case of hypertension, diabetes, 10 years, prior history of L5 radiculopathy already there. He again developed pain in the left thigh, followed by worsening of the existing left foot drop. And grade 3 power left hip flexion, grade 3 thigh adduction, grade 4 left foot inversion, eversion, dorsiflexion. Yes, somebody has come up with an answer, right? That's nice. Radiculoplexopathy, excellent answer, excellent. That's right. That's a very good answer. That's so radiculoplexoneuropathy is the direct answer. As I said now, when plexus is involved, usually trauma and cancer, but diabetes can pitch in. So study the electrophysiology study reports and opine whether radiculoplexopathy is suggested or not in this. You study this. Sensory nerve conduction studies has shown sural left low amplitude, slow velocity. Sural right is normal, and common peroneal sensory absent, right and left both. Motor nerve conduction studies is showing CMAP is low amplitude with conduction velocities diminished or prolonged, and below fibular head or above fibular head both in left side common peroneal nerve is showing abnormalities. The CMAP abnormalities are there, so we have to do EMG anyway. And what is the F reflex? Left side posterior tibial, common peroneal, both F's are prolonged, and H reflex is absent, and H is absent and right also. And then the EMG. EMG is showing fibs and positive shock waves in so many muscles. Paraspinals also it is showing iliopsoas, shorthead of biceps femoris, which is supplied by the peroneal division or fibular division before it leaves the thigh. Peroneus longus, rectus femoris, rector longus, tibialis anterior. All the recruitments and interference are decreased. The amplitudes are normal, but you got fibs and positive sharp waves are seen in these. So all sensory and late responses are abnormal with asymmetric snaps, low amplitude CMAPs, prolonged nerve conduction velocity, spontaneous activity in several muscles innervated by different nerves as well as paraspinals. So there is a problem here that is radiculoplexopathy. Asymmetric snaps are also showing abnormality, and you got a paraspinal abnormality. It is a mixed picture. 8-year-old lady, 150 centimeters tall, underwent left hip replacement. 1 week post surgery, acute onset of pain and weakness in the right thigh. CT abdomen pelvis are normal. Symptoms persisted for 1 month. Clinical evaluation showed reduced strength in the right hip flexors and sensory loss on the right medial leg. Okay, now just observe this. She underwent left hip replacement, not the right one. So, what lab evaluation is preferred? MRI LS spine, MRI left lumbosacral plexus, repeat CT abdomen pelvis, EP electrodiagnostics testing, or CSF. What will you like to do? Oh yeah, right, there are two, right? That's nice. So you would like to do electrodiagnostics, right? Now that is challenging. So electrodiagnostic testing, and what is the diagnosis after you go through this? Sensory nerve conduction studies, left sural is absent, right sural is also absent, and radial is normal, right? CP is this sensation, sensory of peroneal is also absent. The motor nerve conduction study shows the left side posterior tibial has got a low amplitude and velocity is prolonged, and left femoral is absent, right femoral is normal. This is motor nerve conduction studies. And F waves and H reflex. Left H reflex, right H reflex is absent both. The right side F is prolonged and the posterior tibial F is prolonged and common peroneal F is absent. Now you have to go to the EMG. The EMG shows rectus femoris and vastus lateralis as fibs and positive shock waves. Otherwise everything else, and iliopsoas also has got fibs and positive. Now you tell the diagnosis. Want to go back? Where are you finding abnormalities? Tough, huh? Yeah, you got somebody cracked it. Your people are good, you are sharp. Femoral neuropathy, very nice, Suresh. I think you are a master, yeah, right. All sensory and late responses are abnormal except the right radial snap. CMAPs are reduced in amplitude and the femoral snaps are prolonged. EMG shows spontaneous activity in several muscles innervated by the right femoral nerve. So, so the diagnosis is right femoral mononeuropathy. An excellent answer. Which of the following muscles will indicate root level pathology if paraspinals cannot be examined? Root level pathology is indicated by which muscle in this? Yes, you can tell.
Tensor fasciolatus.
Yes, tensor fasciolata. And medial gastrocnemius, sartorius, and erector magnus are not, but this is a root level, right? It's nice, excellent. Right. And the concept here is proximal motor nerve. These are muscles supplied by the nerves that originate before the limb nerves to originate from the plexus. Gluteus muscles, tensor fascial lata. Inferior gluteal nerve supplies the gluteus maximus. Superior gluteal nerve supplies the gluteus medius, minimus, and tensor fascial lata. So that's how the medial gastrocnemius is by tibial nerve. Sartorius is femoral nerve. Adductor magnus is dual supply, sciatic and obturator. Which of the following electrodiagnostic findings will help in differentiating S1 radiculopathy from sciatic neuropathy? This is a question which is very, very interesting. Yeah, isn't it very nice? Absent sural snap, excellent. How?
In radiculopathy, snaps will be spared, sir, because lesion is proximal to dorsal root ganglion.
Mm. So, sciatic neuropathy and S1 radiculopathy, why not H reflex?
Yes, sir. Even H reflex.
Okay, low amplitude PT CMAP, absent sapness agreed. So, low absent saphenous nerve. The sciatic nerve innervates muscles of posterior thigh, all the muscle distal to the knee. It also supplies sensation to the lateral parts of the foot. S1 dermatome does too. That's the reason. S1 also does the it mediates sensory and motor components of H reflex. So absent H reflex would not differentiate S1 radiculopathy from sciatic neuropathy. The sural nerve, however, divides its fibers between tibial and fibular division of the sciatic nerve. The S1 radiculopathy pathology is proximal to a DRG, so SNAP will be normal in S1 radiculopathy and abnormal in sciatic neuropathy. The reason is here. Okay, you people understood this? So don't get confused on absent H reflex, cannot differentiate. 60-year-old man, known case of hypertension, diabetes, hypercholesterolemia, developed acute paraplegia and underwent electrophysiological studies 5 weeks later. There is a sensory level at the level of umbilicus, absent pain and temperature sensations, and preserves vibration, joint position sense. All lower limb deep turning jerks are absent. The EPS shows normal sural snaps, absent PTC maps, absent F waves, and H reflexes. EMG showed spontaneous activity in all muscles in both lower limbs, lumbosacral paraspinal muscles, thoracic paraspinal below T9. No recruitable motor units are noted in any muscle exhibiting spontaneous activity. What is the most likely diagnosis? Diabetic radiculoplexus neuropathy, lumbosacral polyradiculopathy, AIDP, anterior spinal artery syndrome. Hmm, good. Try. You want to just come. Suresh Reddy, you are wrong. It's wrong. That's why this confusion has come. It came after 5 weeks. No, it's anterior spinal artery syndrome only. Right? Right. I'll explain to you why it is. Right. As both sural snaps are normal, so polyneuropathy is excluded. No, it's out. Needle EMG shows motor axon pathology caudal to T9 bilaterally. Anterior spinal artery syndrome, that's the reason. It is the dorsal columns are spared here. Anterior horn cells are infarcted. And there is Valerian degeneration of all motor fibers in the affected territories. Absent F waves, absent H reflexes, widespread spontaneous activity. So, the caution is absent H reflexes are not synonymous with S1 radiculopathies and absent F waves are not pathognomonic of AIDP or GBS. So, just remember this. Your clinical correlation with electrophysiology is very, very important, and Suresh, you faulted here, but anyway, that's okay. Which of the following muscles innervated by sciatic nerve? Gluteus maximus, medius, rectus femoris, tensor fasciae, medial gastrocnemius, and I think it's a very easy question. Yeah, many people have answered this. Right. Gastrocnemius, that's correct, right? The sciatic nerve is derived from, right, shall we read this or not? One second. Yeah. The sciatic nerve is derived from all six lumbosacral roots L2 to S1. It provides dual innervation along with the obturator nerve to the adductor magnus. It supplies the posterior thigh muscles before its division into peroneal and tibial divisions. The peroneal nerve supplies the short head of the biceps femoris, then becomes the common peroneal nerve. The CP supplies all the muscles distal to knee involved in dorsiflexion and eversion. Tibial nerve supplies all other muscles. That's a 50-year-old lady with no significant past medical history presents with 2 weeks history of left foot drop. No medical history. Grade 4 strength in foot dorsiflexors, invertors. Reflexes are 2 plus, symmetric bilaterally. There is decreased sensation over anterior part of the left foot. Which of the following diagnosis is correct? Peroneal neuropathy, L5 radiculopathy, S1 radiculopathy. Oh, already the answer has come. But why reflexes are preserved?
Because ankle is S1, sir.
Huh.
L5 involvement, ankle will be spared.
Right. Oh, that's important point for others to note. Okay, L5 radiculopathy. There's no history of trauma or cancer here, so plexopathy is out. Both S1 radiculopathy and sciatic neuropathy will show weakness in muscles innervated by the tibial nerve. Common peroneal will cause weakness in foot dorsiflexion and eversion. Foot inversion is by tibialis posterior and L5 radiculopathy. So lower limb reflexes are unaffected by L5 radiculopathy as knee is L3-4 and ankle is S1-2. 50-year-old lady with no significant past medical history presents with a 2 weeks history of left foot drop. Grade 4 strength in foot dorsiflexors, everters, inverters. Reflexes are 2 plus. Which of the following EPS will be seen? Electrophysiological changes. Decreased sensation of the anterior part of the left foot also. Absent common peroneal snap, absent H reflex, absent sural snap, conduction block across fibula head, spontaneous activity in lumbar paraspinal muscles. I think it's an easy thing. Already come. Nice. Yes. Yeah, spontaneous activity in parallel. That's very nice. A prolonged or absent H reflex, pathology affecting sciatic nerve or S1 radiculopathy, ankle reflex will be absent. So, the spontaneous activity in the lumbar paraspinal muscles is very important here. So, H reflex abnormalities are usually with sciatic nerve or S1 radiculopathy, and here ankle jerk also will be absent, right? Which of the following nerves is the terminal branch? That we have already read. So, femoral nerve originates from the upper portion of the lumbosacral plexus, supplies this iliopsoas before crossing the inguinal ligament to the innervate the quadriceps femoris and other hip flexors. So, which of the following diagnoses would be associated with absent sural snap? Fibular division, sciatic mononeuropathy, S1 radiculopathy, sciatic mononeuropathy, tibial division of sciatic mononeuropathy, upper lumbar plexopathy. This is very important. We already got it. Yeah, that's nice. Yes. Sciatic mononeuropathy. Excellent. You got chaps are very nice. The sciatic mononeuropathy, sural nerve. We have already discussed about this. That it conveys sensory information from the lateral aspect of the foot and the ankle, bifurcates above the knee such that part of it joins the fibular division of the sciatic nerve, and the remainder joins the tibial division. Snap amplitude is reduced if either tibial or fibular division is affected in isolation, but will not be absent. The sural nerve is connected to lower lumbosacral plexus also. So sciatic nerve is a very correct answer. In a patient with left flail foot, which clinical finding will differentiate S1 radiculopathy from sciatic mononeuropathy? Absent ankle jerk, sensory loss or lateral aspect of the foot, weakness of foot dorsiflexion, weakness of hip extension, weakness of foot plantar flexion. Oh, already. So I think you people are very clued up. That's nice. Hip extension weakness, which I mentioned in the first. So this is weakness of hip extension is very important examination finding, which a flail foot occurs when there is weakness of both plantar flexion and dorsiflexion. CP nerve mediates foot dorsiflexion, that is L4-5 and minimal S1. So only S1 radiculopathy cannot cause dorsiflexion weakness. Foot plantar flexion weakness, loss of ankle jerk, loss of sensation of the lateral foot could occur either from S1 radiculopathy or sciatic mononeuropathy. Hip extension is helped by gluteus maximus muscle. That is a root collateral nerve, inferior gluteal nerve from S1 nerve root. So that's very interesting. And last question: which of the following nerves originate directly from lumbosacral plexus? Last question: which of the following nerves originates directly from lumbosacral plexus?
Lateral
Right.
cutaneous nerve of thigh.
Lateral femoral cutaneous nerve thigh. Right. So that brings us to the end of my discussion today. If there are any questions, and let us share. Otherwise, we'll meet next week with brachial plexus. Peripheral neurology will try and tackle in the next couple of weeks. Okay, students, anything? The last question you want to read? Okay. A patient is referred for a right foot drop of 6 weeks duration. He had lumbar spine surgery 2 years earlier for a herniated disc. And he had grade 4 strength in the right foot dorsiflexion, inversion, eversion. Decreased pinprick over the right grade 2. Reflexes are 1 plus and symmetric bilaterally. NCV is unremarkable. Spontaneous activity with decreased recruitment and interference pattern on right tibialis posterior, peroneus longus, tibialis anterior, short head of the biceps femoris, tensor fascia later. I think this is very easy for you people. You can easily say now. I think you are very clued up about this. Right. Thank you, sir. It's very comprehensive and practical, Suresh. Thank you very much. And this, of course, is the last one. L5 radiculopathy. Short head of the biceps femoris supplied by fibular divisional sciatic nerve. Transfer fascia later is innervated by root collateral superior gluteal nerve. So that finishes. Thank you very much. Good night. Have a nice weekend coming. Bye. Good night.